Hello, my name is Henry Silverman, and today I would like to discuss disclosing errors to patients. What are our responsibilities? These slides are adapted from a presentation from Thomas Gallinger. This slide shows the relationship of errors and adverse events. We see in this slide that adverse events can be divided into what is called non-preventable adverse events and preventable adverse events. Adverse events are essentially expected complications from procedures and administration of drugs. As with all procedures and drugs, there are expected adverse events from procedures and administration of drugs. A lot of the times, these adverse events are non-preventable. For example, giving drugs to patients, there are expected toxicities that are not under our control. However, for example, giving a drug to a patient in which there is a known allergy to the drug, but this was not recognized, can be considered as a preventable adverse event and hence classified as a medical error. On the left side of the screen, we see the entity of medical errors, and we see within this circle what is called near misses. These are considered errors that does not result in any harm to the patient. We will discuss the entity of non-harmful medical errors later on in this presentation. What is the rationale for disclosing errors to patients? Well, one, error disclosure acts as informed consent for the patient and derives from the principle of autonomy and respect for persons. Essentially, we have a positive obligation to inform patients of errors. Error disclosure can be considered as truth-telling for patients. And there are regulatory requirements to disclose errors that comes from the JCO standards and also state laws. There are several ethical complexities in error disclosure. For example, what are our disclosure requirements for the following? One, fatal errors, and I think we'll all can agree that we have a positive disclosure requirement to disclose fatal errors. But what about harmful errors in patients who are hopelessly ill? And what about errors with minor or transient harm? And what are our disclosure requirements from disclosing errors from other physicians? Error disclosure can be thought of as a conflict of interest for physicians. Essentially, doctors have a secondary interest in not disclosing errors that emanates from a fear or prospect of malpractice and peer condemnation. This secondary interest in not disclosing error competes with our interest in our positive obligation to be truthful to patients. What about patients' attitudes about errors? Studies have shown that patients conceive of errors broadly. Essentially, patient studies have shown that patients want all types of errors to be disclosed to them, including non-harmful errors. Essentially, studies have shown that they worry that healthcare workers might be hiding errors from them. Patients' preferences for error disclosure. What information does patients want disclosed about errors? Well, essentially they want an explicit statement that an error has occurred. They want to know what happened and the implications for their health. They want to know why it happened. How will reoccurrences be prevented? And they want to have an apology. They want the healthcare provider to say, "I'm sorry that an error has occurred." What about physicians' attitudes about errors? Well, they define errors more narrowly than patients. As we will see, that they have a restrictive concept of which errors should be disclosed to patients. They agree in principle with full disclosure, and they want to be truthful, but they do experience barriers to disclosure. Accordingly, they choose their words carefully, and will show examples about this in the next few slides. What are the barriers to error disclosure from the physician perspective? Well, there is a concern that disclosure could precipitate a lawsuit. They worry that disclosure would be awkward and uncomfortable for them. Essentially, they have difficulty in admitting to personal failure. They have no formal training in how to disclose error to patients. And sometimes they fear that disclosure could harm the patient, essentially causing emotional upset. However, this is really a misplaced use of the therapeutic privilege. Physicians choose their words carefully when disclosing errors to patients. They avoid explicit identification of an error that has occurred. They assume that patients will ask clarifying questions about the error, and hence they avoid being proactive in talking about the error unless the patients ask. Concerns about legal liability make apologizing difficulty. The next few slides I'd like to talk about physician surveys regarding disclosure of errors. This involved 2,000 physicians at the several institutions, and also included Canadian physicians. And topics included communicating about medical errors with patient colleagues and healthcare institutions. The response rate was 63%. This slide shows the general attitudes about disclosure, and we'll see how they agreed or disagreed with several of these statements. Regarding near misses should be disclosed to patients, 32% agreed that near misses should be disclosed to patients. Regarding minor errors should be disclosed to patients, 77% agreed with this statement. And in regards to serious errors, 98% agreed that such errors should be disclosed to patients. Physicians were also asked to respond to several scenarios. Several of these regarded an overt error regarding an insulin overdose and a retained surgical sponge, and an unapparent error regarding hyperkalemia and bile duct injury during a lap cholecystectomy due to unfamiliarity with a new surgical tool. 5 questions measured the content of disclosure. Each question presented actual disclosure language representing no information, a little information, or full disclosure. Scenario 1 involved an insulin overdose. Physicians were relayed the following scenario. You have admitted a diabetic patient to the hospital for a COPD exacerbation. You handwrite an order for the patient to receive 10 units of insulin. The U in your order looks like a 0. The following morning, the patient is given, accordingly, 100 units of insulin, which is 10 times the patient's normal dose, and is later found unresponsive with a blood sugar level of 35. The patient is resuscitated and transferred to the intensive care unit. You expect the patient to make a full recovery. Physicians were asked, how likely would you be to disclose this error to the patient? In regards to I would definitely not disclose this error, we see that only 0.5% would not disclose this error. 3% would disclose this error only if asked by the patient. Almost 32% would probably disclose this error, and 65% would definitely disclose this error. Somewhat similar figures were shown by the Canadian physicians. The physicians were asked, what would you most likely say about what happened? 1% would say your blood sugar went too low and you passed out. 28% would say your blood sugar went too low because you received more insulin than you needed. And 71% would say your blood sugar went too low because an error happened and you received too much insulin. So essentially, almost a third would not disclose that an error actually happened. How much detail would you most likely give the patient about the error? 11% would not volunteer any specific information about the details of the error unless asked by the patient. 36% would say you received more insulin than you needed. And 54% would say you received 100 units rather than your usual 10 units of insulin. Most importantly, physicians were asked what most closely resembles what you would say about the cause of the error. 11% would not volunteer a cause for the error unless the patient asked. 11% would not volunteer a cause of the error unless the patient asked about the error. 55% would say this error occurred because of miscommunication about your insulin order. And 34% would say my handwriting is sometimes difficult to read. I wrote your order for 10 units of insulin and the U looked like a 0. Therefore you received 100 units of insulin instead of 10. This also slipped by our nurse and pharmacist. What would you most likely say regarding an apology? 3% would not volunteer that he or she was sorry or apologize. 54% would say, I'm sorry about what happened. And 43% would say, I'm so sorry that you were harmed by this error. Essentially, 54% would give what we would call a sympathetic sorry, a sorry in which one sympathizes with the patient that something bad happened, whereas 43% would make a statement that resembles an error of accountability, saying that they're sorry that an error occurred. Second scenario, you start an outpatient with hypertension on a new medicine with a common side effect of increasing the potassium level. The patient's baseline potassium level is normal. You order a repeat potassium blood test to be drawn the next week, but forget to check the lab results. 2 weeks after the patient begins this new medicine, they start feeling palpitations and go to the emergency room. In the ER, the patient experiences an episode of ventricular tachycardia requiring cardioversion. The patient's potassium level at this time is 7.5. The patient is hospitalized for 4 days and makes a full recovery. The patient returns to your office for a follow-up visit. On reviewing the patient's charts, you see the overlooked labs, which showed the patient's potassium had risen substantially from 4.0 to 5.6. Had you seen this elevated potassium earlier, you would have stopped the new medicine and treated the hyperkalemia, likely avoiding the life-threatening arrhythmia. How likely would you be to disclose this error to the patient? How likely would you be to disclose this error to the patient? 0.8% said they would definitely not disclose this error. 12.5% would disclose this error only if asked by the patient. 52.7% would probably disclose this error, and only 34% would definitely disclose this error. What would you most likely say about what happened? 6% would say your potassium level got too high, which led to a dangerous heart rhythm. 55% would say the new medicine we started caused your potassium level to become too high, which led to a dangerous heart rhythm. And 40% would say you had a dangerous heart rhythm because an error happened and we did not notice that the new medicine had caused your potassium to become too high. Scenario 3 regards a retained sponge. You are seeing a patient 3 weeks post elective splenectomy or ITP. That splenectomy was technically challenging due to the patient's obesity, but appeared to be uncomplicated. At this follow-up visit, the patient complains of vague, persistent left upper quadrant pain. You send the patient for an abdominal X-ray, which shows a foreign body consistent with a retained surgical sponge in the patient's left upper quadrant. You remember that the sponge count was correct at the end of the procedure. However, you also remember that you packed off a small bleeding vessel near the stomach with a sponge, and now do not recall removing the sponge. When you review the postoperative records, you observe that a math error was responsible for a falsely correct sponge count. You believe a re-operation to remove the retained sponge is indicated and expect the patient will make a full recovery. How likely would you be to disclose this error to the patient? 0.6% would definitely not disclose this error. 0% would disclose this error only if asked by the patient. 3.2% would probably disclose this error, and an overwhelming 96% would definitely disclose this error. What would you most likely say about what happened? 3% would say the X-ray showed an abnormality that could be serious. Another operation would be required to investigate and correct this problem. 83% would say during the surgery a sponge was inadvertently left in your abdomen. Another operation will be required to remove the sponge. And 14% would say we will have to do another operation because an error happened and the sponge was left in your abdomen. So only 14% would actually admit to an error that occurred. What would we most likely say regarding an apology? 19% would not volunteer to say they're sorry or apologize. 72% would say what is known as a sympathetic apology. I am sorry about what happened. And 9% would say I'm so sorry that you were harmed by this error. Preliminary survey conclusions. Physicians support concept of disclosure. There is little agreement exists regarding the core content of disclosure. Less information tends to be disclosed for errors that would not be apparent to the patient, like in the case involving the hyperkalemia. And medical and surgical physicians may approach disclosure differently. One study looked at nurses' disclosure attitudes. This study was done in focus groups at 4 different institutions. And essentially the nurses support disclosing errors that cause serious harm or require further intervention. They did express concern or worry that disclosing minor errors would scare patients and families. And they are eager to participate with the docs in disclosure conversations, in part so they won't be blamed by the physician. They feel like error disclosure is like walking on eggshells. In regards to the apology, as I mentioned before, well, essentially there are 3 types of apology. There is no apology. There is an apology that offers an expression of regret or sympathy. And then there's the apology of accountability when unanticipated outcome is clearly caused by an unambiguous error or system failure. What about the role of the institution in supporting disclosure? Institutions should offer emotional support for patients, families, and the healthcare workers. There should be disclosure education and building of skills in disclosing errors, and provide disclosure coaching essentially 24/7, 365 days of the week. What do we know about the relationship between disclosure and litigation? Patients who have sued often cite perception that the truth was hidden from them. Essentially, they regard such deficient doctor-patient communication as important motivators to sue. Studies have also shown that disclosure reduces the intention to sue and promotes more favorable settlements. Disclosure reduces the size of jury awards, may make case less attractive to plaintiff attorney. Some institutions have adopted open disclosure policy without deterioration in legal expenses. We do also know that the vast majority of patients injured by negligent care never sue because lack of awareness of error may contribute to this low rate, and some recent analyses do suggest that disclosure may increase overall litigation. There are no randomized controlled data that exist or is likely to exist in the near future about the impact of disclosure on litigation. And this last slide shows several articles about surveys regarding error disclosure. Thank you very much.